Okay, here we will look at some of the neurology MCQ questions for PLAB 1 exam. Tim is a retired 82-year-old postman who takes warfarin for atrial fibrillation. He stumbled on the stairs and sustained a minor head injury 2 weeks ago. He has now become increasingly confused, drowsy, unsteady, and has a GCS of 13. What is the most likely diagnosis? It is indeed subdural hemorrhage. If you find clues in the question like old age, anticoagulants, alcoholism, then you should think of subdural hemorrhage. These happen because of rupture of cortical bridging veins and bleeding into the outermost meningeal layer. Usually it is chronic over weeks or months, but sometimes injury can cause acute SDH. Patient presents with gradual onset headaches, fluctuating consciousness, focal neurological signs, and change in personality or dementia. If you do a CT scan, you can see a crescentic lesion just at the surface of brain, usually unilateral. Management could be just conservative with steroids to manage intracranial pressure or reverse any anticoagulation. Sometimes burr holes are used to evacuate hematoma by irrigation. If there is a repeat collection, craniotomy can be done to remove the collection. Another one, a 47-year-old woman reports pain and weakness in her hands for several months. She has stiff legs and bilateral wasting of the small muscles of her hands. Reflexes in the upper limbs are absent, but both legs show increased tone, pyramidal weakness, hyperreflexia, and extensor plantars. Pain and temperature sensation are impaired in the upper limbs. What is the most likely diagnosis? This is syringomyelia. Because there are no lower cranial nerves involved, this is not syringobulbia. You can see here that as the brainstem is coming down, it becomes spinal cord. Syringomyelia means dilatation of the central spinal cavity as shown by the dark matter in the diagram here. Patient typically presents with loss of pain and temperature sensations, which is caused by lateral spinothalamic tracts, only if the syringomyelia is in the cervical spinal cord. We are going to reflect on neuroanatomy. These are the motor tracts. All the fibers from the motor cortex, they come through the internal capsule and then go into the brainstem and then the spinal cord. The fibers for face will cross over in the pons, whereas those for the arms and legs will continue and cross over in the medulla. Now imagine there is dilatation of cervical spinal cord cavity that will press the anterior horn cells in the cervical spinal cord. So lower motor neuron palsy will happen in the arms. However, at this cervical level, you only have the upper motor neurons for the legs. Hence, there is pyramidal weakness of the legs. Looking at the sensory tracts, there are two types. The one shown on the red are not affected. These are the dorsal column, and dorsal column carries sensation for pressure, joint position, and vibration. These sensations are intact in patients with syringomyelia. Now you can see that the tract shown in black color is the lateral spinothalamic tract, which goes nearby from the spinal cavity and hence these are affected if there is pressure because of dilatation of central cavity of the spinal cord. These tracts carry pain and temperature, and hence patient has a loss of the sensation in the arms. Right. Susie is a 46-year-old woman and presents to the emergency department with headache and vomiting. She was decorating her ceiling that morning when occipital headache began along with some neck pain. A few hours later, she vomited and was unable to walk. She takes no regular medications and has no significant past medical history. Examiner shows normal visual acuity, field and fundi. She has upbeat nystagmus in all directions with normal facial and tongue movements, but speech is slurred. Limb examination shows left arm is past pointing and has dysdiadochokinesia with reduced pinprick sensation in her right arm and leg. Although power is normal, she can't walk as she feels too unsteady. Where is the most likely site of the lesion? This is confusing and you need to know the details of neuroanatomy. This is indeed left-sided lateral medullary syndrome. Right. On this diagram, I have tried to show in the red pen is the blood supply to the lower part of brain, mainly the brainstem and the cerebellum. Medullary syndromes happen if there is emboli or thrombosis within the vertebrobasilar blood supply, which affects the lower cerebellum and brainstem. Also, I want to tell you that the motor tract, the motor fibers travel on the medial part of brainstem, but the lateral part of brainstem has the sensory fibers. In lateral medullary syndrome, you have sensory loss and you will have cerebellar signs. In the medial medullary syndrome, you will have motor signs along with cerebellar signs. You also need to know that apart from first and second cranial nerve, midbrain gives rise to third and fourth cranial nerve, pons gives rise to 5, 6, 7, 8 cranial nerves, and the last 4 cranial nerves, 9, 10, 11, 12, come out of the medulla. So sometimes in medullary syndromes, you can also have these cranial nerves affected. Liz is a 45-year-old teacher and presents with visual problems for 3 weeks. CT scan shows a pituitary tumor. Where is the likely visual defect in her case? Of course, it is bitemporal hemianopia, and I'll explain this now. In the red pen, you can see that in the visual pathway, these carry sensation from the lateral side of the picture, or the outer part, or the opposite part. These red fibers cross over to the other side of the brain and go into the optic tract. The black fibers which carry image from the nasal side continue on the same side. Now, I've shown a few types of visual field defects. If the optic nerve is damaged, of course the right eye will have complete blindness, as shown in the black circle. If the lesion is in midline, for example, because of a pituitary tumor, then you will have the central vision intact, but your patient will not be able to see the lateral part of the image on both sides. This is bitemporal hemianopia. If the lesion is in the optic pathway of the right side of the brain, then there is visual loss of all images coming from the left side of the body. So you get contralateral hemianopia. If there is a small lesion in the temporal lobe, then the opposite side upper quadrant visual loss is there. But if that lesion is further down in the occipital lobe, then the lower fibers, the lower quadrant on the opposite side is affected. Right. Scott had got drunk overnight and was slumped on a bench with his right arm hanging over the armrest all night. When he woke up in the morning, he complained of weakness in the right arm, with a wrist drop and sensory loss over the dorsum of right hand and at the web of thumb. Which nerve is most likely affected? Now you need to know the supply, motor and sensory supply of the nerves in the upper limb. This case has radial nerve affected. This diagram shows that the radial nerve travels in the axilla very close to the humerus and then winds around the bone and then goes to the radial part of the arm. It supplies the wrist extensor muscles. So radial nerve injury causes wrist drop. Sensory supply, radial nerve only supplies on the dorsum of the hand, including the thumb and a total of 3.5 digits. On the palm, median nerve and ulnar nerve supply the sensations.